Tell me something about your experience.
Over the past 5 years, I've had the privilege of working in the medical surgical ward at Mihiraa Public Hospital. This experience has allowed me to develop a strong foundation in patient care, particularly in managing a wide range of complex and acute medical conditions. I've gained proficiency in pre- and post-operative care, wound management, IV therapy, and the administration of medications. Working in a public hospital setting has also taught me the importance of adaptability and quick thinking, as we often deal with high patient volumes and diverse cases. During my time at Mihiraa, I've collaborated closely with interdisciplinary teams, contributing to the development of individualized care plans that prioritize patient safety and recovery. I've also had the opportunity to mentor junior nurses, which has helped me refine my leadership and communication skills. Overall, my experience in a fast-paced, high-pressure environment has equipped me with the skills and resilience needed to provide exceptional care to patients and to handle the challenges that come with the nursing profession.
If you were the nurse for a patient going into surgery, what are the pre-op and post-op teachings you would discuss?
As the nurse caring for a patient scheduled for surgery, my priority would be to provide comprehensive preoperative education to ensure the patient is well prepared and informed. I would start by explaining the surgical procedure in layman's terms, addressing any questions or concerns the patient may have. It is crucial to discuss the importance of fasting before surgery, including when to stop eating and drinking, to reduce the risk of aspiration during anesthesia. I would also go over any medications that need to be paused or continued, emphasizing adherence to these instructions. Additionally, I would teach the patient about preoperative hygiene, such as the use of an antiseptic wash, to minimize the risk of infection. If necessary, I would review breathing exercises or techniques like incentive spirometry, which will be important in the postoperative phase to prevent complications like pneumonia. Postoperatively, my focus would shift to recovery and complication prevention. I would educate the patient on the importance of early mobilization, such as getting out of bed and walking as soon as it's safe to do so, to promote circulation and prevent deep vein thrombosis, DVT. I would explain how to care for the surgical site, including recognizing signs of infection like redness, swelling, or drainage, and when to seek medical attention. Pain management is another critical aspect. I would discuss the prescribed pain relief plan, including the proper use of medications and non-pharmacological methods like ice or relaxation techniques. Lastly, I would provide guidance on diet and hydration, emphasizing the gradual reintroduction of food and fluids as tolerated, and discuss any specific postoperative restrictions or follow-up appointments. By ensuring that the patient is well informed and prepared for both the surgery and the recovery process, I can help reduce anxiety and support a smoother recovery. During my time at Mihiraa, I've collaborated closely with interdisciplinary teams, contributing to the development of individualized care plans that prioritize patient safety and recovery. I've also had the opportunity to mentor junior nurses, which has helped me refine my leadership and communication skills. Overall, my experience in a fast-paced, high-pressure environment has equipped me with the skills and resilience needed to provide exceptional care to patients and to handle the challenges that come with the nursing profession.
If you were working on a floor and a doctor came up to you and yelled at you referring to the patient that wasn't yours and you had not been taken care of, how would you respond?
In a situation where a doctor approaches me in a confrontational manner, especially regarding a patient I am not directly responsible for, my primary focus would be to maintain professionalism and de-escalate the situation. I would remain calm and composed, allowing the doctor to express their concerns without interrupting, as it is important to understand the issue at hand fully. Once the doctor has finished speaking, I would respectfully clarify the situation by stating that the patient in question is not under my care, but I would immediately offer to help by either finding the nurse responsible or assisting in resolving the concern to the best of my ability. After addressing the immediate issue, I would take a moment to discuss the interaction with the doctor in a private and constructive manner. I would acknowledge their concerns and explain that while I am always willing to assist with any patient care issues, it is essential to communicate respectfully and accurately, particularly in high-pressure environments like ours. If necessary, I would suggest discussing this with the unit supervisor or manager to ensure that we are all aligned on communication protocols moving forward. My goal in this situation would be to resolve the misunderstanding, ensure patient care is not compromised, and promote a collaborative and respectful working environment.
If you are a nurse on a floor and one patient is experiencing a transfusion reaction, another patient is in shock, and a third patient with low blood pressure, who do you see first and why?
In this scenario, my first priority would be to assess and manage the patient experiencing a transfusion reaction. Transfusion reactions can escalate quickly and become life-threatening, potentially leading to conditions such as anaphylaxis, hemolysis, or acute respiratory distress. Immediate intervention is critical to stopping the transfusion, maintaining the patient's airway, and initiating appropriate emergency protocols, such as administering antihistamines, steroids, or epinephrine depending on the type and severity of the reaction. Addressing this situation promptly can prevent severe complications and stabilize the patient. Once the patient with the transfusion reaction is stabilized, would then assess the patient in shock. Shock is a critical condition that requires rapid intervention to prevent organ failure and other serious consequences. My focus would be on identifying the type of shock, whether it be hypovolemic, septic, or cardiogenic, and initiating the appropriate treatment, such as fluid resuscitation, vasopressors, or antibiotics, in conjunction with the medical team. Close monitoring and rapid response are essential to improving the patient's outcomes. Finally, I would attend to the patient with low blood pressure. While hypotension can be serious, it is not immediately life-threatening in the absence of other severe symptoms, especially compared to the urgency of the other two cases. I would assess the cause of the low blood pressure, which could range from dehydration to medication side effects, and take appropriate steps to address it, such as adjusting for fluids or reviewing medications. However, this patient would remain closely monitored to ensure their condition does not deteriorate. In summary, prioritizing the patient with the transfusion reaction first is crucial due to the immediate and potentially severe risks involved, followed by the patient in shock, and then the patient with low blood pressure. This approach ensures that the most critical and life-threatening conditions are addressed promptly, aligning with the principles of triage and patient safety. After addressing the immediate issue, I would take a moment to discuss the interaction with the doctor in a private and constructive manner. I would acknowledge their concerns and explain that while I am always willing to assist with any patient care issues, it is essential to communicate respectfully and accurately, particularly in high-pressure environments like ours. If necessary, I would suggest discussing this with the unit supervisor or manager to ensure that we are all aligned on communication protocols moving forward. My goal in this situation would be to resolve the misunderstanding, ensure patient care is not compromised, and promote a collaborative and respectful working environment. Postoperatively, my focus would shift to recovery and complication prevention. I would educate the patient on the importance of early mobilization, such as getting out of bed and walking as soon as it's safe to do so, to promote circulation and prevent deep vein thrombosis, DVT. I would explain how to care for the surgical site, including recognizing signs of infection like redness, swelling, or drainage, and when to seek medical attention. Pain management is another critical aspect. I would discuss the prescribed pain relief plan, including the proper use of medications and non-pharmacological methods like ice or relaxation techniques. Lastly, I would provide guidance on diet and hydration, emphasizing the gradual reintroduction of food and fluids as tolerated, and discuss any specific postoperative restrictions or follow-up appointments. By ensuring that the patient is well informed and prepared for both the surgery and the recovery process, I can help reduce anxiety and support a smoother recovery. During my time at Mihiraa, I've collaborated closely with interdisciplinary teams, contributing to the development of individualized care plans that prioritize patient safety and recovery. I've also had the opportunity to mentor junior nurses, which has helped me refine my leadership and communication skills. Overall, my experience in a fast-paced, high-pressure environment has equipped me with the skills and resilience needed to provide exceptional care to patients and to handle the challenges that come with the nursing profession.
If you have an older patient who has been in bed for 2 weeks, is short of breath, and has a respiratory rate of 40, what do you do?
Given the patient's condition, prolonged bed rest, shortness of breath, and a respiratory rate of 40, I would immediately recognize this as a potentially critical situation requiring urgent intervention. A respiratory rate of 40 is significantly elevated and suggests severe respiratory distress, which could be due to various underlying causes such as pulmonary embolism, pneumonia, or acute heart failure. My first action would be to quickly assess the patient's airway, breathing, and circulation, the ABCs, to determine the severity of their condition. I would also check their oxygen saturation using a pulse oximeter to gauge how well oxygen is being delivered to the tissues. Next, I would ensure that the patient receives supplemental oxygen, starting with a non-rebreather mask or high-flow nasal cannula, depending on the availability and the patient's needs, to improve oxygenation while further assessment is underway. I would then raise the head of the bed to an upright or semi-Fowler's position to ease breathing and reduce the work of the respiratory muscles. Given the patient's history of immobility, I would also consider the possibility of a pulmonary embolism and promptly notify the attending physician or the rapid response team, providing them with a clear report of the patient's vital signs, symptoms, and medical history. While waiting for further instructions from the physician, would closely monitor the patient's vital signs, looking for any changes or deterioration in their condition. I would also prepare to obtain an arterial blood gas, ABG, sample if ordered, as this would provide valuable information on the patient's oxygenation and acid-base balance. Additionally, I would prepare the patient for any potential diagnostic tests, such as a chest X-ray or CT scan, that might be required to identify the underlying cause of the respiratory distress. In summary, my immediate priority would be to stabilize the patient by ensuring adequate oxygenation and calling for emergency assistance, followed by ongoing monitoring and communication with the healthcare team to facilitate a swift and accurate diagnosis. This approach is crucial in managing the patient's acute symptoms while preventing further complications.
If you are a nurse on a floor and the ventilator alarm is sounding and the high-pressure alarm is sounding, what do you do?
When the ventilator alarm sounds, particularly the high-pressure alarm, it signals that the patient may be experiencing an obstruction or increased resistance in their airway, which requires immediate attention. My first step would be to assess the patient visually and clinically to determine their current condition. I would check for signs of distress such as agitation, increased respiratory effort, or cyanosis, and listen for any abnormal breath sounds like wheezing or diminished breath sounds, which could indicate a blocked airway or other complications. Next, I would quickly assess the ventilator circuit and tubing to identify any possible external causes of the high-pressure alarm. This could include kinks in the tubing, water accumulation, or disconnections, which are common but easily rectifiable issues. If the tubing appears clear and properly connected, I would consider the possibility of a blockage within the patient's airway, such as a mucus plug, bronchospasm, or biting on the endotracheal tube. In such cases, I would ensure the patient's airway is patent by suctioning the airway to remove any secretions that might be causing the obstruction. If these initial steps do not resolve the issue and the patient continues to show signs of distress, I would immediately call for additional help from the respiratory therapist or the attending physician to further assess and manage the situation. While waiting for assistance, I would manually ventilate the patient using a bag valve mask, BVM, to ensure adequate oxygenation if the ventilator cannot be promptly corrected. Manual ventilation also allows me to gauge the level of resistance in the airway and to maintain the patient's oxygenation while the underlying problem is identified. Throughout this process, I would continuously monitor the patient's vital signs, including oxygen saturation, heart rate, and blood pressure, and remain prepared to escalate care if the patient's condition worsens. Documenting the incident, including the steps taken and the patient's response, would also be important for continuity of care and for the healthcare team to understand the event and its resolution. In summary, responding to a high-pressure ventilator alarm involves a rapid and systematic approach to identify and resolve the cause of the increased airway pressure while ensuring the patient remains adequately oxygenated and stable. Collaboration with the respiratory team and prompt intervention are key to managing this potentially critical situation.
If you are a nurse on a unit and you have a patient who is asking for pain meds, a patient who is leaving for the OR, and the OR doctor calls and says they are coming up in 5 minutes and you need to have the patient ready, a patient who needs to use the restroom, a patient who feels sick and a patient who wants someone to sit with them, who do you see first and why?
In this situation, prioritization is key to managing multiple competing demands efficiently while ensuring patient safety. My first priority would be the patient who is leaving for the OR, especially since the OR doctor has indicated they will be arriving in 5 minutes. Preparing a patient for surgery is critical because any delays can disrupt the surgical schedule and potentially compromise the patient's care. I would quickly check that the patient is appropriately prepped, including ensuring that all pre-op protocols, such as NPO status, for access, and proper documentation, are in place. I would reassure the patient and provide any last-minute instructions or support to ensure they are ready for the OR. After ensuring the patient is ready for surgery, I would next attend to the patient who feels sick. This situation could indicate a potentially serious change in their condition that needs to be assessed promptly. I would perform a quick assessment to determine the cause of the sickness, such as checking vital signs, reviewing recent medications, and asking the patient specific questions about their symptoms. Depending on the findings, I would provide appropriate care or escalate the situation to the physician for further evaluation. Following that, I would address the patient who is asking for pain medication. Pain management is an important aspect of patient care, as unmanaged pain can lead to complications, hinder recovery, and cause significant distress. I would quickly assess the patient's pain level using a standardized pain scale, verify the appropriate medication dosage, and administer it promptly. This intervention not only addresses the patient's discomfort but also helps to maintain their overall well-being. Next, I would assist the patient who needs to use the restroom. Ensuring this patient's comfort and dignity is important, and this task can usually be completed relatively quickly. I would either help the patient myself or, if time is pressing, delegate the task to a nursing assistant if available. Lastly, I would attend to the patient who wants someone to sit with them. While emotional support is vital, especially for anxious or lonely patients, this request is less urgent compared to the others. I would acknowledge their request, provide reassurance, and explain that I would return as soon as possible to spend some time with them. If appropriate, I might also ask a volunteer or a nursing assistant to check in on the patient to provide interim support until I can return. In summary, my approach prioritizes tasks based on urgency and patient safety, beginning with the patient who needs to be prepared for surgery, followed by assessing the patient who feels sick, managing pain, assisting with personal needs, and finally providing emotional support. This methodical approach ensures that the most critical tasks are addressed first while also attending to the holistic needs of all patients.